So, dear colleagues, dear friends, thank you for the invitation. And now I want to talk about the new guidelines of the European Society of Cardiology from this year for the management of peripheral arterial and, as you can see, aortic diseases. For this year, sorry, this is one of the creators of the guidelines. And as you can see, the decision to integrate these guidelines is based on several key factors. The aorta and peripheral arteries are integral components of the same arterial system. That's why they combine the aortic with the peripheral guidelines. Combining the guidelines provides consistent and standardized recommendation for the management of the arterial diseases as a whole. So let's begin with the problem. The problem is huge. As you can see, peripheral artery disease is estimated to affect 113 million people aged 40 and above globally, from whom nearly half, or 43%, are in low or middle income countries. The global prevalence is 1.5% and increases with age. 15 to 20% of those aged 70 and over one-third of those aged 80 or older. Prevalence increased by 72% from, as you can see, for 30 years, despite the global population growing only 45%. The most important recommendations for 2024 are these five: the chronic nature of peripheral artery disease and aortic disease, the importance of screening, and the necessity of comprehensive treatment strategies, and awareness that this is a chronic disease that needs a lifetime follow-up. So the follow-up is very important. So we have four main components here. As you can see, the first one is diagnosis, the second one, of course, is treatment, but these two last are very important: the follow-up of the patient and, of course, the prevention of the disease. So here you can see that we have the peripheral artery disease is underestimated disease because we do not see it so often, but as you can see, 5 times increased risk of cardiovascular events compared with patients without PRD. So you as cardiologists should emphasize and seek such patients with peripheral artery disease because they are at risk of coronary or cardiovascular mortality. So if you have suspicion of peripheral artery disease, we have to make clinical assessment, and the first line diagnosis is hemodynamically vascular assessment. ABI is the main, and when we confirm the diagnosis, we continue with our treatment modalities. The first line for the diagnosis of PAD is the ABI. It's very simple test that if you find that the patient has 0.9 or lower ABI, so we have a peripheral artery disease. And even some of my colleagues in Bulgaria, cardiologists, have this device MESI, not Leo Messi, but MESI. It's like 4 cuffs, 2 in the arms and 2 at the level of the cuff. And it's automatically make the measurement, the ABI, and that's a screening test for all. They use it for coronary patients, but they found a huge amount of peripheral patients with that test. It's very inexpensive and very easy to use. So the optimal medical treatment is extremely good nowadays, not like 20 years ago. We have so many drugs: antihypertensive, lipid lowering, optimal glucose control, you see, antithrombotic. But the lifestyle is very important here to address the general cardiovascular risk prevention. These are the medications. We will talk about that later. But in the 2024 guidelines, we have the systolic blood pressure should be below 129 and the diastolic below 79. We have other targets for the LDL. As you can see here, we'll start with that. If we have patients with chronic symptomatic PID with non-high risk limb preservation, we should give single antiplatelet. As you can see, ASA or clopidogrel, this is class 1 recommendation. If we have high risk limb preservation or high risk comorbidities, we should give ACE aspirin and 2.5 milligram of rivaroxaban twice daily. This is from the Voyager PID study. And if we have patients requiring long-term anticoagulation, you can see we use only single oral anticoagulation monotherapy. So this is very important. The patients who underwent endovascular revascularization, the long-term antithrombotic therapy, if we do not have high bleeding risk, we use, according to the Voyager PID, we use the aspirin with rivaroxaban, class 2A, and for 1 month. And we can add for 1 month the clopidogrel, but for long term, only aspirin and rivaroxaban. If we have high bleeding risk, dual antiplatelet, according to the operator, 1 or 3 months, class 2A, and single antiplatelet for lifelong, as you can choose between aspirin and clopidogrel. If we have high bleeding risk and the patient needs anticoagulation, as you can see, single antiplatelet and oral anticoagulation 1-3 months, and then only oral anticoagulation. If we have high bleeding risk after endovascular procedure, we do not add antiplatelet and we continue with the oral anticoagulation. And here you can see that patients with diabetes and chronic kidney disease, ABI is not applicable for these patients because of the medial calcinosis, so we should use the TBI index. And with patients above 65, according to the new guidelines, and with cardiovascular risk factors, we should make the screening for PID by ABI. It's a very easy test. In patients with AAA, we should seek FEMPOP aneurysms too, because these two pathologies are mates, and usually we have concomitant progression of the disease of the aorta and the FEMPOP region. In patients above 65 without cardiovascular risk factors, screening for PID by ABI, we have 2B recommendation. So, in patients about the AAA, it is recommended to screen men aged 65 or above with a history of smoking. As you can see, the level of evidence is 1A. In men aged above 75, without, irrespective of smoking history, you should seek again the AAA. So this is about the blood pressure, and I thought that the new guideline says that the blood pressure should be below 130. So I'll go about. So the lipid lowering therapy, all patients with peripheral artery disease should receive a lipid lowering therapy, and the new target is below 1.4 millimole by liter and above 50% reduction in the LDL-C baseline. And these are very strong recommendations, as you can see, 1A. Statins, I want to emphasize about this. Statins are recommended in all patients with peripheral artery disease, and I'm happy to say that in Bulgaria, almost every vascular surgery department, the patient who who goes in these departments, they receive at the discharge obligatory statins or statins and ezetimibe for this indication. If we cannot achieve good results, we can add the PCSK9 inhibitor or bempedoic acid. But as you can see, we have this year the recommendation for the AAA. It's 2A recommendation, but in AAA you should give statins 2, and in thoracic aneurysms you should give statins 2B recommendation. So how to follow up patients, how to diagnose? The first method is duplex ultrasound, and as you can see, the class of evidence is 1C, so every patient with PAD should receive a duplex scan. In patients with symptomatic PAD, the first line treatment, of course, the optimal medical treatment, but the first line treatment should include supervised exercise, and this is class 1A. I don't know, in Bulgaria we do not have such exercise problems, exercise programs. I don't know how it's in Serbia and Macedonia. Do you have exercise programs? No. For co-education? No. Okay. So the antiplatelet, our patients should receive antiplatelets. You can choose between aspirin and clopidogrel. Personally, in my clinic, we prefer clopidogrel for our PAD patients, but the combination treatment is, according to the Verger-Path study, the new combination is aspirin with rivaroxaban 2.5 twice daily. So I want to show you something very interesting from the American guidelines. You can see the American guidelines from the American Heart Association. Only one slide, because we do not have it in the European guidelines, and that's very interesting. They include the cilostazol for the peripheral artery disease as class 1A. And the other interesting thing about cilostazol is that we can give it to our patients to prevent restenosis after endovascular therapy for FEM-POP disease, and the class of evidence is 2B for the cilostazol. So that's very interesting about the Americans. We do not have it in the European guidelines. So we continue with the European guidelines. As you can see, the patient should receive optimal medical treatment 3 months and exercise if 1B level of evidence, and if the quality of life didn't improve after that time, after that 3 months, we should go for intervention. About the intervention, we have here in the FEM-POP region, we should use drug-eluting technology to a recommendation. For the iliacs, we do not have such evidence. So for the iliacs, balloon angioplasty with or without stenting of the external iliac artery, or primary stenting in the common iliac arteries. So there should be a stent in the iliac regions, but nothing, they say nothing about the drug-eluting technology because we do not have such evidence. In the FEM-POP lesions, as you can see, the revascularization, when is indicated, endovascular therapy should be considered, and there are equal level of evidence for the endovascular and for the open surgery if we have a good great saphenous vein conduit. How to follow up? It is recommended to at least 1 a year to follow up such patients, and mostly to see if we have medication adherence, limb symptoms, and cardiovascular risk factors with duplex ultrasound assessment as needed. CLTI patients are very tough patients because they have the worst prognosis. For limb salvage in such patients, it's obligatory, the revascularization is obligatory, as you can see, class of evidence 1B. If you have such patient, the early recognition of the CLTI and the referral to the vascular team are recommended to have the limb salvage. So in CLTI, it is recommended to perform revascularization as soon as possible. And we have another two options. The open surgery, if you have good great saphenous vein, good conduit, the open surgery and the endovascular treatment, as you can see, are equal to B and to B. So it's up to you how to deal with such patients with clear CLTI. For the carotids, as my friend Oliver said, we use the NASCET method, and the duplex ultrasound is the first line imaging to diagnose such stenosis. In my department, we do the open surgery only based on the duplex ultrasound investigation. When we have indications for revascularizations, as you can see, we have asymptomatic patients, and the level of evidence to treat asymptomatic patients is 2A, and the level of evidence to treat symptomatic patients is 1A. For the asymptomatic patients, you can choose between open surgery, 2A, or endovascular treatment, carotid stenting, 2B. So it's 50-50 to treat asymptomatic patients, but for symptomatic patients, the most evidence we have for the open surgery, as you can see, 1A. And this is how to follow up. Another interesting thing this year in these guidelines, we do not have any randomized trials about CAR procedure, but it is in the guidelines, and that's very strange because no randomized trials against carotid desobliteration and carotid stenting. For the symptomatic patients, it's the same. Class 1 level of evidence is for the open surgery, but carotid stenting and CAR can be performed securely in these patients. So some special recommendations, as you can see with peripheral patients with peripheral artery disease, the reduction, the LDL has to be below 1.4, and patients with AF should receive full oral anticoagulation, as you can see, 1C recommendation. So the key messages in this year guidelines that atherosclerotic lower extremity PAD is a chronic disease needing lifelong follow-up. The follow-up is essential. Assessment of low-kick impairment, functional status, and amputation risk is crucial in PID management. And IBI index should be the initial test. According to this test, we can find patients with PID, even asymptomatic one, even hidden one. Supervised exercise, it's okay. Unfortunately, we do not have it in our countries, but we can use the home-based exercise treatment. In asymptomatic PID, patients' revascularization is not recommended. In symptomatic PID, patients need for intervention treatment following a period of optimal medical treatment, and exercise should be discussed in a multidisciplinary session. Chronic limb-threatening ischemia, very tough problem, increases the risk of cardiovascular events, needs early diagnosis, rapid referral to a vascular team, and revascularization for limb salvage. It is essential to revascularize these patients. Acute limb ischemia, rapid clinical assessment, of course, by vascular team, and urgent revascularization. Duplex ultrasound is the first line diagnostic modality. Atherosclerotic arterial disease of the upper extremity is most frequently located in the subclavian artery and may be suspected because of difference in the blood pressure above 15. So duplex again is the first line imaging, and routine revascularization is not recommended for such lesions. The key to early diagnosis of acute and chronic mesenteric ischemia is a high level of clinical suspicion, so we have no specific laboratory test, but in acute SMA occlusion requires immediate revascularization. And with that, I thank you for your attention.